Everybody, my name is Kevin Bartel. I'm the Director of Orthopedics, Neurosciences, and Specialty Practice with Kauai Health. We're very grateful for you to join us today. And we're excited to have all of you here. We have obviously in person and those of us joining online as well for this viewing. And tonight we're really excited for you to hear from two of our orthopedic surgeons that are affiliated with Kauai Health that work locally. And they're going to be addressing different various treatment approaches with hip and knee pain and a few other details as well that they'll get into. So we do invite you to hold your questions till the very end. Please remember them, write them down. For those of you online, please enter your questions into the chat portion of your online platform, and then we'll try to get to those at the end as well. And then also for those of you here in person, I just want to make sure you're aware, we have a really great resource here in the back as well. We have two doctors of physical therapy sitting in the back, Kylie and Rosalie with Kauai Health. They're here specifically as a resource to you all if you have questions about any aches, pains that a therapist may be able to help you out with. So they'll be available and accessible to you as well. So we appreciate again all you coming. And with that, I'll turn it over to Dr. Tan.
All right, so I'm Tim Tan. I'm one of the new orthopedic surgeon that came here about 10 months ago. We practice locally in Visalia, and we have a couple other offices, but mainly I am in Visalia. So I did a fellowship at UCSF in San Francisco for hip and knee replacements. So it's really my area of focus. And I'll give a talk about what's new in modern joint replacement and hip and knee arthritis. So why is this talk important? Hip and knee arthritis is extremely common. More than 30% of people over 45 have hip or knee arthritis. And if you look at people over 70 years old, over 10% of people have joint replacements in them. So just to summarize the talk, I'll just start off. What is actually new? Some things have changed in non-operative management. There's different kind of medications. Dr. Criner will probably talk about PRP. But there's actually been a lot of change in operative management as well. There are new implants. People are putting in implants through different means, such as robots, navigation. And we also now have a better understanding of who we operate on. And I would say that COVID really drove joint replacements to be discharged out of the hospital faster. And we've really focused on rapid recovery joint replacements because of COVID and trying to get people out of the hospital faster. And in order to do this, we are now able to have better pain control. And I think this is really what's driven outpatient joints. So in order to understand arthritis, we should just understand the anatomy a little bit. So in a normal joint, you have a friction-free smooth surface that is lined with articular cartilage. And in arthritis, it's basically cartilage wear and tear of this smooth surface where it's now become rough. So arthritis is the slow development of joint pain. And you often see stiffness and pain as your main symptoms. And a lot of people will use assisted devices later on. A lot of people do ask what the difference between osteoarthritis and rheumatoid. Usually you see osteoarthritis, it's over 95% of the time that's what it is. But in rheumatoid, it's when the body's attacking itself. So here's a pretty good example of the progression of arthritis. So on the left side, you can see a nice smooth white surface. And on the right, when you see arthritis, it becomes almost like a lot of potholes, as you can see there. So you can see the progression of arthritis over the time, and you can see on the right, it's now become bone on bone, and you see a lot of bone spurs as well. Hip arthritis is actually similar. It's a ball and socket joint. And you can see here the kind of progression where you get bone on bone arthritis, as they would call it, or bone spurs. So here are the clinical practice guidelines on what the American Academy of Orthopedic Surgery actually recommends for non-operative treatment. They recommend weight loss, anti-inflammatories, and really rehab, education, and wellness activity. And what's a little unclear is they actually recommend against a lot of supplements such as glucosaminochondroitin, They recommend against acupuncture, even though there's probably not too much harm. Gel shots are actually recommended against arthroscopic surgery as well in the setting of arthritis. And shoe wedges to unload a side is not really recommended as well. And then the recommendations regarding steroid injections, bracing, biologics are a little bit more inclusive. So we can dive into non-surgical management in more detail. So education is really is very important. They found that there's a lot of psychological effects of education with regard to arthritis. Low impact exercise is also extremely important. I never recommend, heavy squats with heavy weights. Usually, I think that's one of the worst things you can do. But as far as low impact exercises, anything in a pool, ellipticals, I think are great too, and just walking on flat ground as well. And weight loss is also something that we often talk about, because they say for every 1 pound of weight lost is 5 pounds less on the knee. And then if you are using an assisted device, which sometimes you have to use it on the opposite side. So aquatic therapy is obviously great because it's a lot less weight on your knee or hip. As far as medications, one of the first line treatments that we do are anti-inflammatories. Over-the-counter treatments that are often common are Aleve, Advil, and aspirin. But recently, they have been developed a lot more longer-acting medications. Like, for example, if you take ibuprofen, which is a short-acting medication, it only lasts 3 to 4 hours. Whereas if you take a long-acting one, sometimes you only have to take it once a day. Topical medications are also out there, such as, I guess, like Voltaren is probably one of the most common ones. You can see it at Costco pretty much anywhere. But it's a cream that you can put directly over any aspect that hurts. And this is very common with a lot of people. They often try this before they see me. And as far as injections, steroids are often I would say the gold standard of what people use. It's often diagnostic, where if you do get good relief with a steroid shot, that's usually a very good sign. The question is how long it lasts. As the arthritis gets worse and worse, they tend to last less and less. And for me in particular, I don't do injections more than every 3 months. So if you needed it in 6 weeks, that's usually not a good sign that it would work again. And then the gel injections have gotten a lot of popularity recently. There's many different types. Some are single shots, some are multiple shots. The main advantage of the hyaluronic acid is if you did have to get a joint replacement, for example, you don't have to wait 3 months like you would for a steroid. And it also doesn't increase your sugars if you have diabetes, which would happen with a cortisone shot. So when do you consider joint replacement? I tell all my patients this is elective surgery. This is not cancer. It's never an emergency. So I let the patients decide almost all the time when they want a joint replacement, because only the patients know when their life is really being affected, when they're not as happy as they want to be. And so I would say the patients are really the people who know when the time is right. So as far as surgical treatment, a lot has really changed in the last 5 years. There's different means of putting in joint replacements. At Kuya, we do have a ROSA, which is a type of robot. But no matter how you put it in, the purpose is really the same. It's to give a balanced knee, and the robots definitely do help you position it more accurately. Partial knee replacements are an option in people who only have a certain localized area of arthritis. You can do it in the patellofemoral joint, which is the front of your knee, which you don't see that often. And then a unicompartmental knee is usually done on the medial side, which is the inner aspect of your knee. But the problem with unis, as these are called, because it's only one compartment, is that oftentimes you see patients who have arthritis in the whole knee or in multiple compartments. So they say that only about 20% of your patients would be candidates for a unicompartmental knee arthroplasty. The other problem is the revision rate is much higher on these unis because the most common failure reason for unis is arthritis of a different compartment. So that's important to consider. So the benefits of a total knee replacement are to decrease pain, improve your mobility. We can make your legs straight. We can correct deformity, and really just improve your quality of life and your happiness. So the materials used in hip and knee are, as you can see above, mostly it's metal and plastic for knees. And for hips, we often use a ceramic on polyethylene surface. I would say this is, for the most part, the gold standard in the United States right now. Another question that we're often asked is, how long will your joint replacement last? So if you look at this data here, over 80 to 85% of people will have a joint replacement that lasts longer than 20 years. You have to remember that this data is from joint replacements that were done over 20 years ago. So we do expect it to last a lot longer now. The benefits of a total hip replacement really are the same with knees. I would say, in general, hip replacements, the recovery is much easier than a knee. I would say it's, half the recovery. Patients are usually, walking out the door or have much better function in 6 weeks, whereas we say it's about 3 months for a knee. So what are the risks and complications of a joint replacement? The biggest risk that we all worry about is infection. I know I worry about that the most because it is the most common reason for a failed joint replacement, and it can be devastating. There are other risks as well, but usually an infection is the one that we really worry about. So how do we know who's at high risk? This is actually a study that I did with Cleveland Clinic a couple years ago, where we looked at the different risk factors. You can see here that the biggest risk factors are going to be smoking and diabetes and weight. So you can see here, like the ideal weight's 30, and it really is an exponential increase as your weight increases a lot. So my hard cutoff, I usually tell people around a BMI of 40 is where I would tell people to try to lose weight to get under that, because the risk really does jump once you reach that point. So this is, I guess, my speech for joint replacements. I say that physical therapy begins the day of surgery, and to me, this is important. The majority of my patients are going home the same day. I would say 80% of my patients are right now. The patients that aren't going home the same day are people that have to go through a lot of steps in their house if they live on 2 floors, or if they have no help at home. It's possible for them to still go home the same day. It's just it requires a little bit more coordination. Also, if they're older or they have a lot of medical issues, I'm more tempted to keep them in the hospital for longer. So you can see here that the projected increase for outpatient or same-day total joint replacements has really increased dramatically. I would say Korea is actually well ahead of the curve. I don't know what the stats are, but I think it's probably around 80%. Whereas some of the hospitals that I operate at, I'm not going to mention any names, but some of them have patients stay there for 3 nights, and that's routine. So I guess when I went there and started doing outpatient total joint replacements, they were just completely shocked, but they do well. And not all your patients end up going home the same day. I would say, in my opinion, the biggest problem is anesthesia side effects, where they often do get nauseous. So we just tell our patients that we plan for them to go home the same day. But if they have to stay over, there's worse things than that. So here are the key elements of our joint replacement optimization and preparation. So one is there's hard stops. There are clear indications when you should not have a joint replacement. For me, it's smokers. I do make them quit for 3 months, and I actually even nicotine test them too. So it's a cotinine level. I do it. In the valley here, meth is a huge problem, and I can't tell you how many patients we found out the day before. So that's a hard stop for me. And then weight and uncontrolled diabetes, or any real medical problems that are uncontrolled. Because for me, it's just not worth it. Because when you operate on a patient, you're a patient for life. So it's just important to reduce the complications if you can. At Korea, there is a joint camp, which is a class that is now in person. A lot of my patients are Spanish speaking, so they go to the online one where they have a Spanish version. But it's important just to be educated on what to expect and what to know about their joint replacement. We schedule the surgery at the location best for you, usually. And then as far as pain control, so the difference between what we do now and what we did before, say 5-10 years ago, is we used to just flood everyone with opioids. We give them a strong medication. They're often sedated, and then they're in hospital for 3 or 4 nights or even longer, and they go to rehab because they're not moving. So now we take it from a different standpoint. We give a whole assortment of medication. I actually send my patients home with 7 different medications, which actually sounds like a lot, but 3 or 4 of them are pain medications, but only one narcotic. The rest are like an anti-inflammatories or Tylenol, and then like a nerve type medication. So that's how we address it now. We give people a cocktail rather than just hitting them with a bomb. And then cold therapy, icing is always helpful as well. So the patients are ambulating within hours of surgery. If they get a spinal, it's usually just when the spinal anesthesia wears off. Physical therapy is important, especially for knees, I would say. I would say hips, maybe a little less. But for knees, it's important to get your motion back, because whatever you get in your first 8 weeks is probably what you're going to get for the rest of your life. And then for discharge, we basically just cater to your needs. If you live alone or you need help, we will send a physical therapist to your house. So in summary, what is new in joint replacement? There's increased recovery. People are going home a lot faster. And I would say a lot of this has to do with pain control and just new techniques on how we do it. There are new approaches, which is a whole nother talk, but I know Dr. Criner and me both do anterior hip replacement, which is shown to have faster recovery. But I would say if you're going to get a joint replacement, just make sure that you see a surgeon who does a lot of them and is comfortable with whatever he does. I think that's the most important thing. There are now different techniques, minimally invasive techniques, which is just smaller incisions, and robots are now available. They're newer implants, but for me, the biggest thing is surgical selection. I think that is the key to having less complications. And we now have all these tools to see to predict who's going to be able to go home the same day or who's going to have an infection or any issues. Thank you.
Okay, so I'm Seth Criner, or Dr. Seth Criner. I'm an orthopedic surgeon here locally. I've been here since 2016. I work with Orthopedic Associates Medical Clinic. I initially did my training in orthopedic trauma and have, I'd say over the last 3 to 4 years, been doing mostly general orthopedics. And then I take call at the hospital about 5 nights a month. And so whenever I'm on call, I do any bad trauma that rolls through the door. But I don't do as much of the bad trauma as I used to as my elective practice is developed. So, and then thank you to Kuya for putting this on. It's always nice to be able to reach out to the community. So this is, I talked about PRP and stem cells in the Weekend Warrior. And so this is me doing silly, stupid stuff that puts me at risk of hurting myself. But just to kind of show everybody I'm a Weekend Warrior, and the athlete in me hasn't died yet. So anyways, so what we're talking about again, PRP, stem cells, and so another thing that they're referred to as is orthobiologics. Okay, and so these are things that we're trying to use to modify the arthritic process and the regenerative process. And there's all kinds of promises out there by all kinds of people. So I'm going to try and, make heads and tails from this for you guys and kind of give you guys some good advice. So what are we going to talk about? We're going to talk about viscosupplementation, which Dr. Tan's already kind of talked a little bit about, which is those lubricant type injections that we can do in the knees. Platelet-rich plasma, or PRP. And then there are things, cell-based therapies, so you can get bone marrow-derived stem cells, so we can get them from out of usually they get them out of your pelvis. You can also do a thing called, that are adipose tissue-derived, so they come from the fat, and it's a kit called lipogem. And then we're not going to talk much about the placental, the amniotic chorion or umbilical cord type stuff. That's kind of been out and around, and there's some FDA regulations around it that don't allow some of that stuff to happen for various reasons, which I'll kind of touch on at one point. But I'm not going to spend a lot of time talking about it. Okay, so we're going to first talk about PRP. So what makes up PRP? So it's blood, and your blood is made up of red blood cells, white blood cells, which we use to fight infection, and it's suspended in a thing called plasma, okay? And the plasma part of it contains things called growth factors and platelets, okay? And those things are good for helping stimulate healing, okay? And so what is PRP defined as? It's a sample of blood with 2 times the platelets above your baseline levels. Sounds really easy to measure, but in reality, when we're sitting in an office and we're drawing blood off of you and trying to figure out whether someone's platelet level is this or that, and the other, you need to be in a lab to figure that out. So we have not gotten that fancy yet with doing this. I'm sure it's somewhere in the future. And then there's different ways that this can be prepared. You can do what's called leukocyte pour. Leukocytes are white blood cells, so it's just the medical name for white blood cells. And so there's a lower white blood cell count in that, which we'll talk about in a minute. And then leukocyte rich, which means there's a lot of white blood cells in it. And then there's platelet pour plasma also. So there's different versions, but the one thing that I can't really change is what your blood levels are on a given day, as far as like, is your white cell count 10 today, or is it 4, or is your platelet count 50, or is it 300? I can't, those are things that I can't change. So, okay. So PRP preparation, what do we do in the office? We do a blood draw. We take about 10 milliliters of blood, which is, smaller than the size of this controller here. And then we put them in a centrifuge. We spin it down, okay, for 7 to 8 minutes. And then on the far, or if you're facing the screen on the far right, if you're looking at it online, it might be on the left. But anyways, you can see a picture of something that is spun down, and the clear yellow stuff is the plasma that's on the top. The red blood cells are at the very bottom. And they have this thing they call, in this picture, the Buffy coat, which it's never this clear in the office. Just, they make it look all pretty for the pictures. It's never this clear. And that's where platelets and the white blood cells are at. Okay. So we just take the platelets and the clear yellow stuff out of it. We leave the red blood cells behind. Okay. So what type of injuries can we use this for? There's really good data on things like the different types of tendinitis. So it originally started with tennis elbow, which is pain on the outside of the elbow. Classically, they talk about tennis players getting it because they're hitting their backhand. Patellar tendinitis, again, it's a type of tendinitis, and that's down at the knee, okay? And then rotator cuff tendinitis. So sometimes people have pain in their shoulder, the rotator cuff's not torn, but they have tendinitis, okay? We'll go through a little bit more detail on those in just a minute. And then it's most prevalent, or some people are using it in arthritis. We'll talk about that too in a minute. And most prevalent use has been in the knee so far, okay? And so just for fun, I put up a picture of a rotator cuff tear, and on the left, the tendon is not attached to the bone. And on the right, you can see the kind of blue and white stuff going through the tendon, and now it's being held down to the bone and it's repaired down. Some people are injecting stem cells into that, and the data is very mixed on it at best. So how does it help tendinitis? So you have the white blood cells, and white blood cells provoke inflammation, okay? And tendons do not have very good blood supply. And so one of the reasons we think that they have a hard time kind of repairing themselves when they get hurt is because of the poor blood supply. And so what we're doing is we're taking white blood cells that are sitting in the plasma, injecting it into the tendon, and then that's going to stimulate some inflammation in the area, and we're trying to get the white blood cells to stimulate that tendon to heal itself, okay? And so inflammation caused by the white blood cells. It helps stimulate the healing process for tendons. I tell all my patients this, I used to think this was a bunch of voodoo. It was something that was sort of starting to get done when I was in training from 2010 to 2015. You're starting to see articles on it, about it, and some of them said it worked, some of them said it didn't. But I can tell you from personal experience, I had tennis elbow. I don't know how many cortisone injections I had in it over 2 years, but it was too many. I finally caved and just fine, I'll do the PRP injection. And lo and behold, it worked. And so that's one of the things that got me to like, okay, maybe this really does work. So I've been doing PRP injections for tennis elbow. I won't do the tennis elbow surgery on somebody unless I've done that injection on them, because the PRP works just as well as us doing surgery. So you don't take it to surgery until I've done that. So how does it help an arthritic knee? So in arthritis, they talk about having leukocyte plasma, easier said than done, because so arthritis is an inflammatory process. The knee's inflamed, it's irritated, it's upset. And so what they think is if you have a bunch of white cells in the plasma, and white cells tend to cause inflammation, are you going to further inflame the knee? Okay, that's the kind of theory on it. PRP does not regenerate cartilage. Stem cells do not regenerate cartilage. I know people claim that it does. They are lying. Anyone who knows me knows that I'm pretty blunt. So they're lying. It kind of is upsetting to me when I see people get charged $3,000 to $5,000 for stem cells, telling that their cartilage is going to get healed. It's ridiculous. What PRP does, though, what we think it does is it helps decrease inflammation. And the way it does this is because of the growth factors that are sitting in the plasma. Okay. And so they think it helps preserve cartilage, so maybe decrease the rate of deterioration of the cartilage, but it will not regenerate cartilage. Okay. And so you can see in bold there, it helps delay the deterioration of cartilage. I would say that the jury is still out on the use of PRP in joints for arthritis. There's data that supports it, there's data that doesn't, and there's so many different ways of getting the PRP and how people it gets processed that I feel like the data is a little bit hit or miss. I think there's probably a place for it in mild to moderate arthritis, but severe bone-on-bone arthritis, I think it's mostly a waste of time. So, okay. And PRP is not covered by your health insurance. The only insurance that will pay for it is workers' compensation, and generally better not to be in that land. So there's several studies that actually show the use of viscosupplementation, which is lubricant injections, and the use of PRP. So if you do viscosupplementation plus PRP together, they show that it can be more effective than just the lubricant injections by themselves. The problem is a lot of private insurances are no longer paying for the viscosupplementation because of the recommendations that Dr. Tan got into with the American Academy of Orthopedic Surgeons. There's a lot of people that don't agree with those recommendations because those studies that they used, there's like 90 studies on this, and they used 14 of the 90 studies, and they weren't all particularly well done. And so there are issues with the research. So people are trying to go back and look at it again, and hopefully the American Academy of Orthopedics looks at it again and maybe changes their position, because I do think it helps in the mild and moderate stage. But again, severe arthritis, I mean, I'll try it if somebody really wants me to, because Medicare does pay for it. But bone on bone, it doesn't work very well. And so cost for PRP out of pocket, it kind of depends on where you go. We out of pocket charge $150. We make our own kits. We figured out how to do this. I'm a surgeon. That's how I make my living. I feel like it's kind of wrong for me to charge somebody $500 for something that doesn't cost me a lot of money to make. Plus, if it doesn't work and you paid me $500 for something that doesn't work, you tend to start to question my credibility. And, what's most important to me is I'm a surgeon and I fix stuff. So we charge $150 over at our office is what we currently do. So, but if you go to Simonian up in Fresno, I think he charges $750. I think Spock charges $500. So anyways. Oh, and one thing I want to talk about, at the bottom, you can see the different stages of arthritis. So on the left of the screen, it is obviously not arthritic, whereas on the far right, that's where you start to get into bone-on-bone land. And that's where PRP, total waste of time. So here's an x-ray. And so on the left, normal knee joint. On the right, bone-on-bone arthritis. Okay, you can see that the bones are touching. They're not supposed to. That's where the cartilage is supposed to live. So, okay. So viscosupplementation, kind of hinted at it a little bit already. It's controversial. It's made up of something called hyaluronic acid. It's a naturally occurring lubricant. It promotes smoother joint movement. It reduces friction in the joint, and it can maybe slow the progression of arthritis. Okay. Again, good for mild, moderate osteoarthritis, tends to not work very well for severe. Stem cells. Okay. We can get these from fat using a kit from a company called Lipogem. I don't do this. One of my partners has done it a couple of times. He hasn't been totally thrilled with it. And so I have never felt a desire to do it. And it costs like $3,500 or something like that. And so we take a little bit, we make small incisions, take a little bit of fat from the abdominal area because most of us have a little something extra there. So we'll get to that in just a sec. And then you can also use a thing called BMAC, is the abbreviation, but it's bone marrow aspirate concentrate. Typically, we can get that from the pelvis, and so they can do it in the office or in an operating room. You make a small incision on the back part of the pelvis, and you get down to the pelvis, and then you put a metal cannula into the bone, and you suck out about 60 cc's of blood out of the pelvis that has stem cells in it, and then you have kits to process it. Okay. So how do stem cells work? Because of the growth hormones and different things that live in blood, they can help modulate the local environment and help deal with inflammation. Okay. And so hence the next line, decrease inflammation. Recruit other stem cells. Okay. And then they can secrete growth factors. So these stem cells can actually secrete the growth factors that can help decrease the inflammation. Okay. But they, like I said, does not regenerate cartilage. So here's kind of a picture of the Lipogem. They're sticking a small needle. It's like liposuction kind of, but we don't need nearly as much fat. They take it, and then there are rules from the FDA on this about what we can do with stem cells, and we really can't do anything to change them. You can just spin things down, pull the stem cells off, and then inject them, and that's it. And I'll get to the reasons briefly in a few minutes. The other thing is what's called BMAC, bone marrow aspirate. So on the far left is a picture of a pelvis, and they're sticking that cannula into the pelvis. And then you take out about 60 cc's of blood and you spin it down, and then you're left with your bone marrow aspirate, which has the stem cells in it. And then you inject that. A lot of people are doing the place where this is most commonly done is with rotator cuff repairs. So people will do the rotator cuff repair, and then they'll inject the stem cells underneath the tendon to try and help further stimulate healing. The data is all over the place on this. To get ready for this, I was doing research on it, and you have, Dr. A says this is great, I do it on everybody. You have Dr. B say this is stupid, it doesn't work, don't do it on anybody, it's a waste of money. And so the jury is out on it. So I don't do things this is one of the things I don't do because there isn't good data on it. So So most of the research on this has been done in the setting of surgery. The idea is to try and enhance healing of a rotator cuff. Rotator cuffs can re-tear. I have a guy that I'm trying to fix next week. I fixed him in 2019. He had a fall, did something, 3 years later, tore again. Some suggestion, like I said, it helps with rotator cuff healing, but it's controversial. It's the most common place people use it. Other places are with anterior cruciate ligament reconstructions, so athletes who tear their ACL. And then when dealing with cartilage defects, there may be some benefit to it, but these defects are literally like 1 by 1 centimeter. So we're not talking about the person with bad arthritis. We're talking about, the 25-year-old who tore his ACL and dinged his cartilage in an area. And so maybe some benefit for that person. Okay. And the last thing I want to touch on is watch out for medical tourism. I'm not kidding. I had somebody in my office today who goes to Mexico to get stem cell injections, and they are paying thousands of dollars to do this. And so what do? They take your stem cells and they grow them. And then you come back 6 to 8 weeks later and they inject them back into you. The FDA does not allow you to do this in labs here in the US. There's some very minor, small exceptions for this. And the reason that we do not do that is because there are people who've done stuff where they've had injections into their eyes and they've gone blind. You've had people who've had these stem cells injected into their spine and then develop spinal tumors. And so, and this is very different than the lipogem BMAC. And so when I was talking earlier about processing of cells, et cetera, this is why the FDA has the rules in place that don't allow us to really do anything to these stem cells that we're getting with those things, because the concern is that we can cause a tumor. So, okay, conclusions. PRP can be helpful. I think it's really good for tendinitis. I suspect it's helpful for mild to moderate arthritis in the knee. I've done it in that situation because I've had people come in and they just want to try it. One of my partners, Dr. Duncan's also done it in these and had some reasonable success from him and I talking about it. Severe arthritis, it's a waste, in my opinion, a waste of time. Viscosupplementation, jury's still out. Likely helpful, I think, for mild to moderate arthritis. Stem cells can be helpful, but they can cost thousands of dollars. So I'm always, is it really worth it? If I don't know, if you're Elon Musk, it probably doesn't matter. But I'm not Elon Musk, so. And then stem cell tourism is dangerous. There's a reason the FDA doesn't allow certain things. Okay, so here's me having some more fun. So just again, stupid. I used to be a personal trainer, so before I went to medical school. So I've done plenty of stupid stuff over the years. And then the other thing then you're jumping off the ball, playing golf on the weekends. So anyways, okay. So thank you, everybody. And then I think now they're going to have some questions for us.
Maybe you just invite you to pass it.
Yeah.
Would love for everyone to be able to ask any questions you have for Dr. Tan and Dr. Criner at this time. You can go and sit there. And then when all the questions are done, Dr.
Criner. Yeah, go ahead.
How long does PRP last, the effects?
So when I've done PRP, so some people, it takes one injection and their tennis elbow gets better. In my case, and I've had this with some of my patients also, the first time it worked for a couple months and then it wore off. So I did it a second time. And that was back in February of 2021. So now it's been 18 months and I haven't had to do anything to my elbow again. I mean, I used to get out of the OR after every case and I'd be like shaking my arm because my elbow hurt so much after the case. So, and I'm doing that 7 times a day and it's just, anyway, so it can vary, but I don't think I've had to do it more than twice in anybody. When it comes to the arthritis side, I have a guy, the main guy that I end up doing it in who has pretty mild arthritis in his knee, and he's a correctional officer. And we've done it 2 to 3 times in the last year and a half. So it's like every 6 months maybe. And I kind of tell him, just call us when it wears off and we'll get you in and figure it out. So, but the first thing is you got to know that someone has mild arthritis. So we do x-rays. And a lot of times I'm going to be looking for something else. So if you have not very bad arthritis, I'm probably going to get an MRI and see if you have like a meniscus tear or something like that before I start injecting PRP into your knee. Yep.
I had partial knee replacements done 9 years ago, and I'm dealing with arthritis now. If you do a total knee replacement, does that get rid of the arthritis, or will that come back? You can repeat the question.
Okay, so the question is, I guess you had a unicompartmental partial knee. It's been 9 years, and now there's progression of arthritis to the other side or the other aspect. That is very common. The revision rate or needing a redo surgery after uni is about 10% at 10 years. So oftentimes it may not be a permanent fix. It would be buying time. But you can rest assured that if you were to get converted to a total knee replacement, the results are no different than if you were to just go straight to a total knee replacement.
And sometimes it's good to hear it from 2 people. I completely agree with everything he said. So I do probably 3 to 5 unicompartmental knees a year out of maybe 150 joint replacements, 200 somewhere in there, whatever it is. And it can advance. And so, but you do the whole replacement, you shouldn't need anything again as long as nothing bad happens.
Now, they did my first one, and then they would not do the second one for a year after that. Is that normal?
Oh, you mean the other side?
The other knee. They did one knee and waited a year to do the other one to see how everything progressed.
Tim can answer for himself. I don't make people wait a year. The lady I just saw today who happened to do a partial knee on, who I've also done a knee arthroscopy, so I know that her other compartments are perfect. We did her one knee in March, and then we just did her other partial knee in August. But I have people who come in at 2 weeks and they're like, can you go do the other knee? Because my knee replacement's better than the other one. So
For me, it's 3 months would be the soonest I would do the next side. I like, yeah, to me, that's enough recovery to go ahead with the next one.
that one.
Okay, so this is I guess a call-in question. Does taking glucosamine and conjoint do anything for you? I would say this, I don't think there's any harm, but as far as hard data, I think there's very little that it actually shows a difference. But theoretically, in my mind, at least it makes sense that it would, but the data doesn't show that.
And then I got a question about how many PRP treatment sessions on average are needed and how often. Kind of touched on this a little bit earlier. And so, and I would say it's also just totally all over the board because it depends on what you're doing it for. Because it's in an arthritis situation, if it is legitimately helping, you're not fixing the arthritis. So theoretically, you're probably going to be doing it again, or the arthritis is going to progress to a point where you're getting most likely a total joint replacement. As far as things like tendinitis type situations, like a tennis elbow, I haven't had to do it more than twice in people. So, how often? The guidelines, like for tennis elbow, I tend to split them apart by 6 months. If you're having to do it more frequently, then probably need to change your game plan and what you're doing. And then some people will with the viscosupplementation, which is a series of 3 injections for knee arthritis. I've seen it where people do PRP for every injection, which when you start doing the math, 150 times 3 is $450. And then if you're getting it in both knees, it's $900. So it starts, and that's with what we charge in our office. And you have a lot of places that charge $500. So, and then there are other places where they'll put the PRP in the 3rd injection where they just do it once. So.
Another call-in question. What is your infection rate for joint replacement? I have not had any infections of me actually doing the joint replacement. I've done a lot of redo surgeries of infected joint replacements. There is a saying, if you don't have an infection, you just haven't done enough joint replacements, because it will happen with time. The national average is about 1%. And I do have the data from Kuya. In 2021, there was only one joint infection. It was a superficial surgical site infection. And I can imagine that there's probably been over 2,000 or 3,000 a year.
Oh, we're not that busy.
Not that busy?
We do about 500 a year. I think it's around 500 a year.
That sounds about right.
It's 400 to 500. It's been a little bit weird lately because of COVID, because it really, for a while during COVID, the people we were doing joint replacements on were literally only the people we knew we were going to be able to send home the same day. And so I think it's around 500 joint replacements a year between the different surgeons. So, but one infection, I mean, it's a 0.25%. It's been like that since I've been here since 2016. So.
I would say Kuya has incorporated a lot of measures to prevent infection. They always make sure we give antibiotics before surgery. They swab the nares, because usually when you get an infection, it's from your skin. So they'll actually check for that. And we have all these solutions that we run through to prevent infection.
Does it take long to get into your office?
Repeat the question.
Does it take long to get into the office? I was told today that they're booking at the end of October in my office. But I've been here for 6 years, and so.
I'm not as busy as him, because I haven't been here as long.
Yeah.
So it'd probably be, a couple weeks, and then probably 1 month out for surgical booking.
We're trying to bring more surgeons here, but it's a little bit hard to recruit at times. So.
I understand.
Yeah.
But if you want a PRP treatment, are you the one, or is Dr. Tan the one?
I think we're really the only guy in
That's
our
right.
office in Orthopedic Associates. Myself and Dr. Duncan are the main guys that are doing it for knee stuff and whatnot.
I don't really have a lot of pain. It's just kind of giving way. And I had an x-ray recently. I had an x-ray about 3 years ago, and they told me it was arthritis, but I don't have pain, but I want to get it handled now.
Yeah. Well, there are lots of reasons why your knee can just decide to give out. So it could just be a meniscus tear sometimes too. It depends on how arthritic the knee is.
Okay.
So, but we'll know based on x-rays. It takes about 2 seconds to look at it and figure it
I had
out.
a pacemaker, and they wouldn't do an MRI. So
Yeah. How long has the pacemaker been in?
my pacemaker, it's been about 8 years.
Okay. Right. There are MRI safe pacemakers,
Oh, good. Okay.
but you have to find out from the manufacturer whether yours is MRI safe. And so I have had patients who have MRI safe pacemakers, and I've gotten MRIs and not had an issue. It's a little bit more legwork because the people who run the MRI are absolutely terrified that something's going to happen.
But you're going to be able to tell if you have arthritis versus a tear with an x-ray?
No, that's where you have to get like an MRI potentially. It depends. It depends on how bad your arthritis is.
Oh,
If you have severe arthritis, we're not going to waste time with an MRI.
it's severe.
I would say this, if you're getting an x-ray, make sure it's a weight-bearing x-ray that you're standing, because a lot of times if you go to your PCP and they just order an x-ray, it'll always be lying down because they're worried you're going to, so you'll never see arthritis. It's kind of like a flat tire in a car. If you just take the tire and put it sideways, it's never going to be flat.
Yeah, it's not infrequent that I'm sure Dr. Tan has the same experience where I have to send people over to just see, or we have x-ray in our office, so just send them down the hall real quick and get the x-ray with them standing up. And I've had people who have x-rays where the joint space looks pretty good, not too bad. And then you get that x-ray and it's bone on bone. Happens at least a couple times a year. So.
Appreciate it. You guys mind hanging around for a minute? Yeah. Have a one. Certainly want to say thank you to Dr. Criner and Dr. Tan for being here. So, locally, they're two of quite a great group of orthopedic surgeons that we have here in Visalia, always looking to recruit more quality surgeons. But, our goal at Kauai is to provide quality, safe care from an orthopedic standpoint. Our doctors are really engaged in this process with Kauai. And so to highlight Dr. Tan's point, in a matter of 3 years, our total joints at Kauai, 3 years ago, about 60% of those were going home same day, and now about 86% of them are going home same day. 86%. And that doesn't happen unless it's a safe way to do that. So again, if you want to find out any more information about our orthopedic doctors locally, please check out the Kauai Health website and our orthopedic services page. You can find a list of everybody that we're affiliated with. You can obviously Google search who's local too. Our goal is to keep the care local because we believe that we provide really great care locally. So with that said, the doctors are going to be able to hang out for a little bit. So if you have specific questions, want to engage, I invite you to do so. And then please don't forget, our doctors of physical therapy are primed and ready for your questions back there too. They even have a table to do any movement screens or just check things out if you have questions, okay? Appreciate everybody coming.